All right, welcome to this explainer. Let's jump right into the trauma bay today, where we're going to explore some of the most critical, high-stakes scenarios in clinical trauma management. When a patient crashes through those ER doors, the clock immediately starts ticking. We call this the golden hour, right? It's that tiny window where literally every single decision dictates whether a patient survives or not. So this explainer is going to distill all those crucial diagnostic criteria and life-saving interventions into the clear, strict rules you absolutely need to know.
Okay, picture this scenario. A 27-year-old man arrives with a gunshot wound, and the entry point is right below the nipple. The stakes couldn't possibly be higher. So what's the most likely surgical pathway here? Are we looking at option A, a laparotomy for an abdominal injury, or option B, a thoracotomy for a chest injury? Keep this specific scenario in the back of your mind, because the clinical rules we're about to uncover will give us the exact answer very soon.
Section 1. Abdominal and facial traumas.
Let's test your clinical instincts with this vignette. A young athlete develops sudden lower abdominal pain, and it sharply escalates into severe tenderness the moment they contract their abdominal muscles. So what's the most likely diagnosis? Is it A, acute appendicitis, B, a ruptured ovarian cyst, or C, an abdominal wall pathology?
If you guessed C, you hit the nail on the head. The answer is an abdominal wall pathology, specifically a rectus sheath hematoma. Why does this happen? Well, it's caused when the epigastric artery ruptures, which essentially pours blood straight into the rectus sheath. Now, while our vignette showed it happening to a young athlete during vigorous exercise, it's super important to remember this also frequently occurs during pregnancy or in patients taking anticoagulant therapy.
So how do you actually figure this out at the bedside? It all comes down to the Carnot sign. When you ask the patient to contract their abdominal muscles, you really need to pay close attention. If the tenderness increases, you're dealing with an abdominal wall pathology, just like our hematoma. But if the tenderness actually reduces upon contraction, then the pathology is intra-abdominal. It's such a simple physical exam maneuver, but it is incredibly powerful.
Once you suspect it, how do you confirm it for sure? Well, here's your golden rule and a major exam pearl. Your investigation of choice is going to be a CT scan. It's basically 100% sensitive and specific for this condition. On the scan itself, you'll usually spot a classic spindle-shaped mass within or right behind the rectus muscle, and maybe even a contrast blush if there's active bleeding going on. The good news here, thankfully, most of these cases can just be managed conservatively without rushing into surgery.
Before we move on from localized trauma, let's take a quick look at the face, specifically orbital blowout fractures. Say a patient sustains a fracture to the orbital floor. What specific finding tells you they need urgent, immediate surgery? It's the entrapment of the inferior rectus muscle. Clinically, you'll see this as the patient having a total inability to move their eye upward. That restricted upward gaze means the muscle is literally trapped in the fracture line, and you have to urgently release it surgically to prevent permanent damage.
Section 2. Penetrating neck hemorrhages.
All right, here's your next clinical scenario. A 20-year-old woman is brought in with a stab wound just above the angle of the mandible. Her vitals are perfectly stable, but you notice a neck hematoma that is rapidly enlarging. What is your immediate next step? A, a CT scan. B, a Doppler ultrasound. Or C, operative exploration.
The answer is absolutely C, and the reason is that an expanding neck hematoma is what we classify as a hard sign of vascular injury. That means it mandates immediate surgical exploration, no waiting around. The other hard signs you absolutely have to memorize are active, pulsatile bleeding, clinical shock, airway compromise, and any acute neurological deficit. If you see any of these, you head straight to the OR.
Okay, so this brings us right back to that opening question we had. The golden rule of trauma dictates that any gunshot wound below the nipple has to be considered an abdominal injury until proven otherwise, meaning it requires an exploratory laparotomy. However, if you place a chest tube and you see massive blood output, specifically an initial drain of more than 1,500 milliliters or an ongoing drain of more than 200 milliliters per hour over 4 hours, well, those are your strict indications to pivot immediately to a thoracotomy.
Section 3. Sucking chest wound crises.
Now we're looking at one of the most terrifying injuries you can encounter, the open pneumothorax, more commonly known as a sucking chest wound. This is one of the 6 immediately life-threatening thoracic injuries, and the pathophysiology here is brutally fast. Because there's a defect in the chest wall, air rushes straight into the pleural space from the outside environment, instead of going through the trachea. This rapidly causes lung collapse, profound hypoxia, and if you don't fix it right away, fatal respiratory failure.
So what's your move right there on the floor? Step 1 is immediate.
you apply a 3-sided occlusive dressing right over the wound. This essentially acts like a flutter valve. It lets trapped air escape when the patient exhales, but prevents ambient air from being sucked back in when they inhale. Step 2, which is the definitive treatment, is to insert an intercostal chest drain. Just make absolutely sure you place it completely away from the original wound site.
Now here is a massive exam pearl you simply cannot forget. Taping all 4 sides of that dressing is incredibly dangerous. If you completely seal the wound, you trap the escaping air inside the chest cavity. Literally within seconds, you'll convert a somewhat manageable open pneumothorax into a highly lethal tension pneumothorax. So always leave that 4th side open.
Section 4. Iatrogenic pleural complications.
Let's solve a quick bedside mystery here. A patient becomes tachypnic and hypotensive with noticeably distended neck veins right after a right subclavian central line insertion. What iatrogenic complication just happened? A. Cardiac tamponade, B. Tension pneumothorax, or C. Massive hemothorax?
The correct answer is B. During the procedure, the needle accidentally punctured the pleura. This created a one-way valve, letting air flow into the pleural cavity but not back out. That's a tension pneumothorax, and it presents with a highly testable triad: hypotension, distended neck veins, and absent or severely decreased breath sounds on the affected side. The air pressure in there is literally collapsing the lung and crushing the heart, completely blocking venous return.
I really want to emphasize this exam pearl. Tension pneumothorax is entirely a clinical diagnosis. If you see that classic triad, you do not wait for an X-ray. You need immediate needle decompression or chest tube insertion. Interestingly enough, an accidental pleural puncture is also the single most common complication of an intercostal nerve block, so you really need to keep your index of suspicion high anytime needles are anywhere near the chest wall.
Section 5. Major thoracic vessel injuries.
Check out this deceleration injury vignette. A 40-year-old patient is pulled from a high-speed road traffic accident. Their vitals are extremely unstable, and you notice a massive bruise straight across their sternum. This specific combination of massive blunt force deceleration along with severe anterior chest wall trauma should immediately make you suspect one highly lethal injury, a traumatic aortic rupture.
So here is your roadmap for survival. On the physical side, if you see fractures of the sternum, the scapula, or specifically the first and second ribs, you have to suspect aortic injury. I mean, it takes immense force to break those specific bones. Radiographically, the absolute classic screening sign on a chest X-ray is a widened mediastinum, specifically greater than 8 centimeters. You might also spot a blurred aortic knob, a left apical cap, or the trachea visibly deviating off to the side.
Well, we've covered a lot of ground today. Localized hematomas, expanding neck wounds, sucking chest defects, and catastrophic vascular ruptures. In a trauma bay, every single second counts. The difference between life and death is often just a rapid recognition of these exact signs we just talked about. So will you know what to look for when the clock starts? Keep these visual diagnostic tools fresh in your mind, because one day you might just be the person who stops that clock. Thanks for learning with me on this explainer, and I'll catch you in the next one.